Assalamu alaikum warahmatullahi wabarakatuh. Good morning, guys. This lecture is about elective treatment of colon and rectal cancer. I'm Mosab Shetiwy. In today's lecture, you will learn an overview of management of primary colon cancer, principles of surgical resection of colon cancer, overview of management of rectal adenocarcinoma, surgical principles and techniques of rectal cancer resection. Pre-treatment clinical staging is best accomplished by physical examination with particular attention to ascites, hepatomegaly, jaundice, lymphadenopathy, CT scanning of the abdomen, pelvis, and the chest. In patients with newly diagnosed invasive colon cancer, preoperative scans can demonstrate regional tumor extension, regional lymphatic and distal metastasis, and even tumor-related complications. These findings may assist in selecting the therapeutic approach. An important point is that the finding of isolated liver or lung mets on preoperative studies may not necessarily alter the surgical approach to the primary tumor, particularly in patients who are symptomatic from colon cancer by bleeding or impending obstruction. You should have an idea about colorectal carcinoma's incidence, diagnosis, and investigations. As we've mentioned, colorectal cancer is the third most common in the US, and its incidence varies in different countries. Like in Egypt, is the seventh most common cancer. Many risk factors and pre-malignant conditions are described, like adenomatous polyps. Diagnosis is usually made by colonoscopy. So let's start with the management of primary colon cancer, which actually depends on the staging and the presentation of the patient. The treatment is divided into three categories. A category for colon resection, treatment of localized disease, carcinoma in a polyp or malignant polyps, synchronous lesions, and an overview of management of locally advanced cancer. As for complicated diseases with bleeding, perforation, or obstruction, there will be a separate lecture demonstrating this condition. We'll also have an overview of metastatic disease, and metastatic colorectal carcinoma actually is divided into two categories. Resectable metastatic disease, which is with isolated liver, lung, ovarian, or even peritoneal mets, or unresectable metastatic disease. Unresectable metastatic disease might be in an asymptomatic patient or in a symptomatic patient. So let's start with the localized disease. The aim of resection of colon cancer is to completely remove the invasive tumor, its major vascular pedicle, which contains or surrounded by lymphatics and lymph nodes to this affected segment. 80% of the cases of colorectal carcinoma present with localized disease, and only 20% at presentation show distal metastasis. As you know, different solid carcinomas or solid tumors, the only curative modality of colon cancer is surgical resection. After resection of a segment of bowel, restoration of the bowel continuity by primary anastomosis can be accomplished and achieved in most patients who are having uncomplicated presentation and uncomplicated surgery. Sometimes a temporary proximal diverting colostomy or even ileostomy may be necessary, like in the photo, patient who had rectosigmoid carcinoma, underwent rectosigmoidectomy or sigmoidectomy with a defunction with a proximal diverting left colostomy. So here there is no primary anastomosis done because this patient had either diffuse peritonitis or perforations, or his medical condition was unstable, so he couldn't or wouldn't tolerate a primary anastomosis. يعني the incidence of leak, risk of leak is increased with such conditions. And of course, with obstructing left-sided colon cancer, it's debatable, and it is actually the preference of the surgeon whether to do a proximal diverting colostomy in an obstructed left-sided colon cancer or do primary anastomosis. Laparoscopic colectomy is preferred more than open colectomy for non-obstructed, non-perforated, non-locally advanced colon cancer, especially on the right side, because laparoscopy, comparable to open surgery, have the same oncologic and surgical outcomes, but actually they have better post-operative outcomes like faster recovery than the open surgical techniques, and of course less pain, earlier hospital leave or discharge, which is better than open surgery. After we had an idea about the aim of resection and the principles of surgery, let's get into more details about the different presentations of colon cancer. First, let's start with the malignant polyp. If a polyp is encountered and it looked malignant on colonoscopy, it should be excised completely. Endoscopic polypectomy is sufficient for malignant tumors, except if they show these criteria on histopathological examination. That means that if the pathological report of polypectomy after endoscopy or colonoscopy said that it is polydifferentiated or with positive lymphovascular invasion, or with positive margins after resection, there is still residual disease inside the colon, or if the tumor is T1, deep T1 lesion or tumor invading lower third of submucosa, or even T2 or higher, this indicates segmental resection of the colon, and polypectomy is not enough. Actually, this is a very important topic because the majority of colorectal carcinoma arise from polyps, as you all know, the adenoma carcinoma sequence, and the malignant potential of adenoma to turn malignant is dependent on the size, the histology or grade of histology, and degree of dysplasia. As for the localized disease, localized resection or segmental resection of the primary tumor with complete mesocolic excision is mandatory. Complete mesocolic excision means that regional lymphadenectomy is done following or by division of major blood vessels at the origin to enable removal of draining intermediate and central lymph nodes. And you should know, according to the anatomy, surgical anatomy of the colon, the blood vessels that are to be ligated for resection of different parts of the colon, like for example, right hemicolectomy, the blood vessels ligated should be the ileocolic and right colic branches of the superior mesenteric artery. For malignant diseases, we do complete mesocolic excision, like in the photograph on the left for this left-sided lesion. But actually, for benign diseases, we just perform segmental resection without ligating the vessels centrally, as in the photo on the right which depicts a case of inflammatory bowel disease in the left colon. Synchronous lesions means two or more separate lesions in different parts of the colon. For synchronous cancer, the treatment will be either with extended resection, like for example, if the patient is presented with a cecal cancer and hepatic flexure cancer, then this patient would benefit from extended right hemicolectomy. But for example, like in the photo, if the patient had right and left-sided synchronous cancers, then subtotal or even up to total colectomy may be performed in such cases. And actually, this is an uncommon presentation, as we've mentioned before, because it occurs in less than 5% of the patients. The extent of resection is also influenced by the underlying diseases, because colorectal carcinoma not only arise on top of adenomatous polyps, but also arise on top of inflammatory bowel diseases like ulcerative colitis, for example. Ulcerative colitis denotes granulosa inflammatory disorder of all segments of the colon and rectum, and such patients, when they are treated with surgery for dysplastic or malignant lesions, would benefit from total proctocolectomy, and so what's left is just the anal canal, and so we do an ileoanal anastomosis. Well, actually, we perform a pouch, which is called ileopouchoanal anastomosis, and this pouch may be in form of one of three shapes like S, G, or W shaped pouches, like in the photo in the lower part of the slide. Total colonic resection for cancer involves removal of the entire colon, and it's associated mesentery, like as I've mentioned, with the underlying disease like inflammatory bowel disease or double malignancies, and this is a photo that shows such a condition. Next, the locally advanced disease. 10% of tumors tend to spread directly to nearby organs, and so this mandates in-block resection up to multi-organ or vessel resection to ensure an R0 resection and thus improve disease-free survival and overall survival. And that is seen in some cases with, for example, right colon cancer, locally advanced, that penetrates through the wall of the colon to the anterior abdominal wall, for example, or to a nearby structure. So the aim of resection of carcinoma, curative resection of carcinoma, is to reach an R0 resection, which means that there is no residual disease in the surrounding tissue, or in other words, it is resection with negative margins of adjacent structures all around. Treatment of complicated colon cancer will be discussed in another separate lecture. Lastly, metastatic disease presents about 20% of all cases of colorectal cancer at presentation. Common sites are the liver, followed by the lung, and then the peritoneum. Actually, surgery for metastatic colon cancer provides a potentially curative option for those patients with isolated or limited single-site metastatic disease. Initial management of patients who present with stage 4 or metastatic disease is individualized. It should be discussed in an MDT setting, and in general, the choice and sequence of treatment guided by the presence or absence of symptoms or complications, as we mentioned before, related to the primary tumor, will be discussed. So if this metastatic disease is resectable, means that it's isolated, the single site met in the liver or lung or the peritone, it could be resected. But if the patient is showing unresectable disease, then the management depends on the presence or absence of symptoms from the primary tumor. So for those with unresectable metastatic disease, if the patient is asymptomatic, well, giving the relatively low risk of bleeding or obstruction, less than 10%, a relatively higher rate of perioperative morbidity of asymptomatic patients with unresectable metastatic disease, it's advisable not to do a resection of the primary. But for symptomatic patients with metastatic disease, like those who are presented with bleeding or obstruction or so on, then it's advisable to resect the primary even though the patient is metastatic. And the treatment here is by salvage colectomy or whatever, so that we are limiting, or we are treating the symptoms of the patient. Contraindications of resection of a primary tumor is the presence of unresectable metastatic disease without symptoms or complications, as we've mentioned. And so, as we've mentioned, unresectable or incurable metastases with symptomatizing patients would benefit from palliative surgery. This palliative surgery might be resection of the primary tumor with primary anastomosis, or just a diverting end colostomy with a mucus fistula, or a bypass procedure. A bypass procedure, for example, if the patient is showing a left colon cancer obstructing and it's unresectable, with the patient is metastatic already. So a bypass procedure, like between the ileum and the distal part of the sigmoid, for example, to anastomosis to bypass the obstruction, which is unresectable, or the patient wouldn't tolerate such a major surgery. So just a bypass procedure may be sufficient. Yani also, this will be discussed with the lecture of complicated colon cancer. Let's get into rectal cancer surgery. Actually, rectal cancer surgery is a little bit more detailed, a little bit more difficult. This is the algorithmic approach. Actually, it's a very big algorithm. I'll provide a separate slide for this algorithm if you want to have a look at it. And of course, the optimal approach to treating rectal adenocarcinoma would depend on number of factors and number of settings, like location of the disease in the rectum, the local disease extent, and these are the most important points that guide the resection. For some patients with limited invasive carcinoma anabolic, for example, who have no adverse features, bolibectomy is sufficient. But for those who have locally advanced, extensive fixed bulky tumors or extensive nodal disease, these will be they will benefit from chemoradiotherapy or chemotherapy as first line of treatment, followed by surgery according to their response, and so on. So let's start the management of colorectal carcinoma. All colorectal or rectal adenocarcinoma above T1, that is T2 or more, must be evaluated through an MDT setting, where the radiologist, pathologist, radiation and medical oncologists, and of course the surgeon are present, and all of them evaluate the patient with T2 or more tumors. As you may remember, for the TNM, T1 tumor is the tumor that is mucosal or intramucosal, or extending into the submucosa, but didn't reach the musculosa. So this C, or clinical T1N0 disease, could be resected locally if and only if the disease has all of these criteria. One missing denotes that local excision is not enough. These criteria are a superficial T0 or T1 lesion, of course, no nodal disease or metastatic disease, the tumor is less than 3 centimeters, the margins of resection of this polyp or disease is margins are more than 3 millimeters. The involvement is less than a third of the bowel circumference. The histology is favorable, well-differentiated histology. No perineural or lymphovascular invasion. The mass is not fixed but mobile. And lastly, if the patient is able to comply with post-operative surveillance, because these lesions may have a tendency to recur even if they are superficial lesions. If the patient is not compliant to post-operative surveillance, then local excision is not preferred. Other than that, if all the features are present in a tumor or in a setting, then local excision would suffice. We'll get into little more details about local excision techniques like transanal excision or transanal endoscopic surgery, which is either transanal endoscopic microsurgery or transanal TME. And lastly, another form of local excision that's rarely used nowadays, the posterior excisions that are transsphincteric or transsacral from the back. T2 and 0 tumors, well, they have higher risk of lymph node metastasis. About 10% of T2 tumors metastasize to regional lymph nodes. So local excision by endoscopy or colonoscopy is not enough. Okay, so transabdominal surgery like laparoscopic surgery, low anterior section laparoscopically, or even abdominal perineal is preferred. So that's the T2 lesions. Local excision is not enough. They must do radical resection of this segment. As for T3 or T4 tumors or node positive disease, surgery is not the first line of treatment. Actually, it's chemoradiotherapy, and this is called neoadjuvant chemoradiotherapy, and it's given in conventional fractionated concurrent style or dose, and that is the recommended dose worldwide. It takes about 5 to 6 weeks for the patient to finish the concurrent course of chemoradiotherapy, and then he's referred to surgery. Another regimen that was used but not favored by Americans, the Swedish regimen, the short course high dose radiotherapy, is given for 5 days and then the patient is referred to surgery. Why we do this? Why do we start with chemoradiotherapy in such locally advanced or node positive tumors? There are benefits. The first and most important of which is sphincter preservation, because such big tumors or locally advanced tumors may approach to the internal sphincter, especially in the middle or lower third rectum. And so when we're doing surgery up front or as a primary line, then the sphincters may be involved and the patient is left incontinent. So local resection is not feasible, and at this setting we may do an abdominal perineal resection. But if we gave neoadjuvant chemoradiotherapy, we may preserve the sphincters and their function, and that's a very important value of neoadjuvant chemoradiotherapy for low rectal tumors. Other benefits like lower anastomotic stenosis, like if we're doing primary anastomosis or any anastomosis in any colon or intestinal parts of the GIT, there is an incidence of stenosis at this site of anastomosis. It's lower after the patient receives neoadjuvant chemoradiotherapy. For locally advanced disease, unresectable or bulky disease, or so on, of course, surgery has no role again. We give conventional or long course chemoradiotherapy. This is the preferred approach. Another approach is induction chemotherapy like FOLFOX followed by fluorpyrimidine based concomitant chemoradiotherapy, and this is referred to as total neoadjuvant therapy. I think this will be stressed on in a lecture of the adjuvant and neoadjuvant treatment of GIT tumors in another lecture. Metastatic disease is either, as we've mentioned, potentially resectable or unresectable. If the disease is potentially resectable, it's better to start with short course radiotherapy. Then we do synchronous resection of the primary and secondary tumor. And there are other courses or regimes available, like, for example, long course chemoradiotherapy, then followed by surgery of the primary and secondary, and so on. As we've mentioned, for unresectable disease, if the patient is symptomatic, then we can just perform a diverting stoma, because it's usually symptomatic from obstruction, so on. We can do palliative resection if there is life-threatening bleeding. And lastly, SIMS or metallic stents can be used in such settings of obstructing lesions, but they are actually not preferred in low rectum. So the self-expanding metallic stents may be used in unresectable symptomatic disease. As for the asymptomatic patient with unresectable metastasis, of course, there's no rule for surgery first, so we give chemo, radiotherapy, and if the metastasis disappear, then he may benefit from resection of the primary. You should be aware of the surgical anatomy of the rectum, its relations to the surrounding, especially to the pelvic floor, to the sphincters, and so on. Actually, in selecting a surgical treatment for a patient with rectal cancer, the surgeon must be aware of the following items: the distance of the lesion from the rectal ring and the anal verge. The higher the distance is, the better the surgery or the easier the surgery, and the lower the distance or the minimal distance, the more difficult the surgery it will be. Also, invasion into the lateral pelvic walls, which is radial extension of the disease, invasion into other abdominal organs, the size of the tumors, the lymph node invasion, as well as pelvic anatomy. Like, for example, in males, surgery is more difficult because obese males, for example, tend to have very narrow pelvis, making transabdominal surgery very difficult compared to females. And a very important point is the pre-surgical function of the anorectum or anorectal sphincter. So if the patient is incontinent from the beginning before surgery, then it is not logic to perform low rectal anastomosis in a patient who is incontinent. So here the decision would change into, for example, abdominal perineal. And vice versa. If the patient is continent before surgery, then we try to preserve this continence as much as possible. So we've had so far the algorithm or approach to managing a case of colorectal cancer. Okay, now let's get into more details into the surgical options. As we've mentioned before, T0 and superficial T1 tumors benefit from local excision. T2 to 3 tumors, node negative, may have or benefit from transabdominal surgery, which is either sphincter sparing procedure or abdominal perineal resection. You should know the criteria for abdominal perineal resection. Abdominal perineal resection means removal of sigmoid, rectum, and anal canal, and performing a permanent left colostomy. This is exclusively for patients with invasive T2 to 4 tumors who meet one of these the following criteria. A negative distal margin of 1 centimeter cannot be achieved with any of the sphincter sparing procedures, so a compromised margin is encountered, so there is no value of doing sphincter sparing surgery with a very close margin. This is not radical, so abdominoperineal is indicated. For locally advanced low-lying rectal cancer that is lower than 4 centimeters from the anal vag, or 4 centimeters or less, abdominoperineal surgery is indicated. And as we've mentioned, if the patient is incontinent from the beginning, then this patient with rectal cancer should do an abdominoperineal resection. Let's now review the other two options. Local excision is performed, as we mentioned before, either transanal excision with proctoscope, and the surgeon tries to remove the ulcer or the lesion with safety margin, and this will be enough if we followed the criteria that we've mentioned before of local excision of early or superficial tumors. This also could be done with TES, or transanal endoscopic surgery, like TEO. Okay, this TEO is a transanal endoscopic operation. Is done with a proctoscope that's similar to the transanal endoscopic microsurgery. So the one to the left is the TEO. It depicts the placement of operating endoscope inside the rectum, and then the operating instruments are used to remove this superficial local mobile tumor. On the other hand, transanal minimally invasive surgery, or TAMIS, may be utilized. This is the photo to the right, and this is insertion of boards, surgical board like the one utilized by single incision laparoscopic surgery. This is the gel board, or a board with gel on its top, and the instruments are inserted within this gel material to avoid air leak. Insufflation is done, and multiple instruments can be used in this TAMIS surgery to provide or to do local excision with the criteria that we've mentioned before. As for larger tumors, T2 tumors, transabdominal rectal cancer surgery can be performed using either open surgery, laparoscopic surgery, or even robotic surgery. Curative resection of rectal carcinoma is carried out with either techniques. The techniques are comparable in the results. There is no preference of one over the other. So it's according to the surgeon's experience with open laparoscopic surgery, or even robotic if the Da Vinci system is found or available in the locality. Let's review the surgical resection principles of rectal carcinoma, whether you're doing transabdominal laparoscopic low anterior resection or abdominoperineal resection. You have to do total mesorectal excision, TME. We'll get into a little bit details about this. The section margins here differ from those of the colon. That's why I've repeated this slide again. Proximal margins are the same. 5 centimeters are enough away from the tumor, or proximally. But distally, because of the rectum is smaller, and the rectum actually is in contact with important structures like the internal sphincter. So 1 centimeter distal to the tumor is enough as a distal margin, as a resection margin. And another term that you should be aware of, which is the circumferential radial margin, the CRM. Radial margin of more than 1 millimeter is enough as a resection margin. So to ensure complete resection or wide resection of this segment of the rectum, radial margins must be not involved with the tumor with the tumor tissue of more than 1 millimeter, and that's why preoperatively we do extensive workup for rectal cancer cases like with EUS or MRI pelvis to delineate this circumferential margin preoperatively and tell us or give us an idea about the lateral spread of the tumor. The same lymphadenectomy procedure is also required with adequate staging after removal of 12 or more lymph nodes of the lymphatic basin of the affected segment of the rectum. So what's a TME? TME is a total mesorectal excision. So this is a rectum, okay, and the surrounding tissue is the mesorectum. Mesorectum contains blood vessels and lymphatics. We're actually concerned with lymphatics. Total mesorectal excision must be including all of the mesorectum. So during surgery, if that's a technical aspect, if you encountered part of the wall of the rectum during surgery, if you saw part of the wall, this means that you have wasting of the specimen, and this is not preferred. This means that you have left part of the mesorectum here in this waste, or even you may perforate the specimen while resection or during resection, and this compromises radicality. So after the introduction of the transanal surgery to rectal surgery, actually, or GRT surgery, it's now there is a choice or debate between which is better. Is it a must to do transabdominal surgery, either low anterior section or abdominal veneal with TME, or is there a rule or a value of TATME or transanal total mesorectal excision? Well, actually, TATME is used in experienced centers. It's used particularly for very low tumors, and as we've mentioned before, in difficult settings like in obese males with narrow pelvis, I can't approach to the lower rectum transabdominally, then TATME here would facilitate the resection. That is a photo of transanal TME set, and I think we adopt this technique in our center. You may find lesions, patients with low rectal lesions being treated with this approach. As an additional point, I want to show you some photos about the local excision techniques during endoscopy. The number of techniques that could be utilized, and they are chosen depending on the endoscopist reference, the location of the polyp, and the criteria of the polyp. As you can see in the photo, polypectomy is mandatory for polyp-like lesions in the colon or rectum, because biopsy may not be enough, because it may escape malignant focus away from the. This is an example of polypectomy utilizing what's called the endolobe. There are two primary goals for polypectomy, of course. The first is to completely remove all of the neoplastic tissues with a safety margin more than 3 millimeters. And the second is to provide a tissue sample that can be evaluated histologically. There are a number of techniques for excision, like endolobe, as I've mentioned. Okay, this is resection of a dunculated colonic polyp with the long stalk, and the endolobe is seen in C. A snare polypectomy can be also utilized in some settings. In larger sessile polyps, endolobe may not be sufficient, so they utilize a technique called piecemeal excision of this large sessile mass, and so as not to leave any residual disease or pieces behind, a net is introduced to collect these these pieces. Sometimes bleeding is encountered, and so they insert hemoclips at sites of bleeding. So that ends up the treatment of colon and rectal carcinoma. Let's have a quick look on anal cancer treatment. Anal cancer is actually a rare or uncommon disease. According to the anatomy, the anus is divided into two halves. The upper half is above the dentate line, 2 centimeters above the dentate line. The commonest disease there is squamous cell carcinoma. And this is the primary or first line of treatment is going to be chemoradiotherapy to downstage the tumor, and thus low anterior resection with anti-sphincteric surgery is feasible then. For recurrent or residual disease or compromised sphincter, abdominal perineal resection is done. If the lesion is adenocarcinoma, then if it is feasible, you can do wide local excision, and usually it's not so. Abdominal perineal resection is done with adjuvant chemoradiotherapy. For anal cancer at or below the dentate line, so here the sphincter is compromised by default. The usual lesions there will be the AIN or anal intraepithelial neoplasia on top of HPV, strain 16 or 19 infection, or even HIV. Here, with AIN or intraepithelial lesions, just wide local excision is enough, okay, because sphincters are away from the epithelium a little bit. So, but for other cases like squamous cell carcinoma, usually the patient will be coming or presenting with fecal incontinence, so the only option will be abdominal perineal resection. By the end of this lecture, you should have learned that surgery is the cornerstone of curative therapy for non-metastatic colon and rectal carcinoma. Pre-treatment clinical staging is mandatory because the management depends on the pre-treatment staging and, of course, on the presentation of patients. Majority of colorectal carcinoma arise from polyps. These polyps, if they are encountered early enough to be endoscopically managed when sticking to predefined criteria, then that is all what it is about, the resection or excision. But for uncomplicated localized colon cancer, resection, segmental resection with laparoscopy is more preferred than open surgery. Segmental colectomy must respect resection margins, 5 centimeters all around, with complete mesocolic excision. As for rectal resections, transabdominal resections must respect also negative margins, 5 centimeters above or proximal, 1 centimeter distal, and negative circumferential radial margin, with, of course, total mesorectal excision. That's all, folks. These are contact details. Thank you for listening, and we hope to meet you soon, and good luck.